Welcome to Section 2 of Renal Embryology. In this section, we'll be discussing the pathology associated with renal embryology. So let's get started. Here is a list of renal pathologies that relate to embryology, and we will start with Potter syndrome. And sometimes this is called Potter sequence. The basic premise is that there is failure to excrete urine into the amniotic fluid. Interestingly, fetal urine makes up a significant portion of the amniotic fluid. So failure to excrete urine can lead to oligohydramnios, a word that means there's not enough amniotic fluid. Now, insufficient urine excretion can be caused by many issues, including placental insufficiency. Basically, if the fetus isn't receiving enough blood, then there's not enough blood to filter and produce urine from. So there will be decreased urine excretion. Another cause is renal agenesis, also multicystic dysplastic kidney, MCDK, which is something we'll discuss later, or autosomal recessive polycystic kidney disease, ARPKD, which we'll also dive into more down here. And another important cause is posterior urethral valves, which we'll discuss as well. So we know that Potter syndrome involves oligohydramnios. Well, what does that mean for the fetus? Well, it can actually cause multiple issues. Here's what happens. Without all that amniotic fluid, there's decreased protective cushioning for the fetus. This leads to fetal compression, which can cause a twisted face, as well as skin and extremity defects. Here is a depiction of a fetus with Potter syndrome. There isn't enough amniotic fluid cushioning the fetus, so it gets compressed, leading to visual deformities. In other words, you can visually see these deformities, such as a twisted face and abnormal or underdeveloped limbs. And at the root of all this is a urinary defect of some kind, which is what led to the oligohydramnios in the first place. Another thing that happens is that there's decreased fluid inhaled into the lungs. Normally, the fetus will swallow amniotic fluid, and this fluid will offer structural support to the growing respiratory system. However, in these fetuses who don't have enough fluid to swallow, the developing lungs will be compressed. So instead of the amniotic fluid going into the developing lung tree and exerting pressure outside, the growing lungs are actually getting compressed from the outside. So they're not able to fully develop. So the lungs get compressed and are unable to fully develop. And this leads to pulmonary hypoplasia. So with the background knowledge of Potter syndrome, let's discuss some specific pathologies, starting with renal agenesis. This occurs when the ureteric bud fails to develop. If it fails to develop, then metanephros development will not occur. Recall from the previous lecture that the metanephric mesoderm and the ureteric bud require reciprocal induction to properly form a kidney. So if the ureteric bud isn't present, there will be no kidney. This is the image from the previous lecture which shows the ureteric bud. And you can see that pale pink budding or diverticulum from the mesonephric duct. Now, if renal agenesis occurs on both sides, so a bilateral pathology, then the fetus will not be producing any urine, so there will be insufficient urine excretion. And this leads to oligohydramnios and Potter syndrome, which we already discussed. If the renal agenesis only occurs on one side, so it's a unilateral pathology, then there will be hyperfiltration of the developed kidney. In other words, that one kidney is carrying too much of the load. This can lead to several things, including renal hypertrophy, which makes sense because that kidney is overwhelmed and working overtime. So the tissues will experience hypertrophy. This also increases the risk of renal failure, and that makes sense because the kidney is simply getting overworked. Now let's talk about multicystic dysplastic kidney, or MCDK. What happens here is the ureteric bud and the metanephric mesoderm will interact abnormally. This results in the metanephric mesoderm failing to differentiate, which means there's a non-functional kidney that ultimately results in the formation of cysts and cartilage, where there should be functional structures which contribute to filtration. But instead, there's just cartilage and cysts. So this means decreased urine excretion. Now, the outcome is very similar to that of renal agenesis. If it's bilateral, you ultimately get Potter syndrome. But if it's unilateral, then that one functional kidney will experience hypertrophy and might actually experience renal failure. It's just getting overworked. Now let's discuss autosomal recessive polycystic kidney disease, or ARPKD. This is an autosomal recessive condition that leads to cystic dilation of the renal collecting ducts in both kidneys. And all the cysts are large, so the condition results in bilateral kidney enlargement. And these kidneys are so full of cysts that they can actually be dysfunctional. So there's renal failure, which means decreased urine excretion. And since it's bilateral, these patients will experience Potter syndrome. Now, there's also an autosomal dominant polycystic kidney disease. However, the autosomal dominant form doesn't impact the fetus the way that its autosomal recessive counterpart does. And this table is focused exclusively on renal pathology associated with embryology. So that's why we're only talking about the autosomal recessive form here. Now let's discuss posterior urethral valves. This condition occurs in males, and it involves a membranous remnant of the male urethral valve, and it's located at the bladder-urethral junction. So it actually causes obstruction of the urine from the bladder to the urethra. And since the bladder struggles so much to expel urine past this membranous remnant, it will become enlarged and hypertrophied. And the lack of urine excretion, of course, leads to decreased urine excretion, which eventually leads to oligohydramnios and Potter syndrome. Additionally, that high pressure within the bladder will lead to something called vesico-ureteral reflux, and that can lead to hydronephrosis. Let me explain that concept visually. The left image depicts a normal urinary system in a male fetus. We can see the urethra, the bladder, ureters, and the kidneys. The right image depicts a male fetus with a posterior urethral valve. At the junction of the bladder and the urethra, you can see this membranous blockage, and the bladder trying to squeeze against this will become hypertrophied. And the high pressure in the bladder will cause urine to actually reflux up this way. You can see those arrows going up the ureters. This is called vesico-ureteral reflux. Vesico for bladder and ureteral for ureter. And all this refluxing upward can lead to a buildup of urine in the renal calyces. You can see these renal calyces bulging up here, whereas they were really small before. This is called hydronephrosis. This reflux and hydronephrosis actually predispose the patient to recurrent UTIs. And that's a logical outcome because urine isn't moving out of the body as it should. And all this urine just hanging out up here creates a nidus for infection. And that can be bladder infections, cystitis, or kidney infections, pyelonephritis. Now let's discuss uretopelvic junction obstruction. In this condition, the junction near the renal pelvis and the ureter will fail to canalize. If this happens, urine cannot pass the uretopelvic junction. This means urine will build up in the kidney, which describes hydronephrosis. The left image shows the normal kidney. We can see the ureter, we can see the renal pelvis, and we can see the uretopelvic junction. The right image shows uretopelvic junction obstruction. This will lead to buildup of urine in the kidney, or hydronephrosis. And just like we discussed before, when you think of hydronephrosis, think about recurrent infections. And in this case, since the obstruction is so high, you're thinking mainly of pyelonephritis, or infection of the kidney, not the bladder. Uretopelvic junction obstruction often occurs alongside vesico-ureteral reflux. The mechanism for why these two occur together is not fully understood, but we know that vesico-ureteral reflux can lead to hydronephrosis as well. In other words, there's two reasons for you to expect hydronephrosis in this condition. Regardless, if this occurs bilaterally, then you're going to expect recurrent UTIs and Potter syndrome. If it's merely a unilateral pathology, which thankfully is the most common form, then the patients will only get recurrent UTIs instead of also having Potter syndrome. Now let's discuss duplex collecting systems. This describes unilateral bifurcation of the ureteric bud, and that's before it's able to contact the metanephric mesenchyme, or metanephric mesoderm. And ultimately, this results in a duplicated or bifid ureter. Recall from the previous section on normal renal embryology that the ureteric bud interacts with the metanephric mesoderm, and this occurs in a process called reciprocal induction. In duplex collecting systems, the ureteric bud will bifurcate before forming that relationship with the metanephric mesoderm, and ultimately this leads to a duplicated or bifid ureter. Now this is a radiograph which demonstrates a bifid ureter. You can see that right here. Contrast this to the patient's right side, which only shows a single ureter. And this duplicated or ectopic ureter is very narrow, and this narrowness can lead to a few problems, including obstruction. And if there's obstruction of outflow through the ureter, then urine will build up in the kidney and cause hydronephrosis. And as we discussed, this will result in recurrent UTIs. In some cases, that narrow ureter will attach directly to the bladder, and in that case, that narrow ureter will lead to vesico-ureteral reflux, which again can directly result in recurrent UTIs or result in hydronephrosis, which will then cause recurrent UTIs. Now let's discuss horseshoe kidneys. These often occur with Turner syndrome, or several of the trisomies, including trisomy 13, 18, and 21. In this condition, the inferior poles of both kidneys fuse together. This results in a horseshoe-shaped kidney. Normally during development, kidneys will ascend from the pelvis, and it will go higher near the lumbar vertebrae. But because of this fusion at the inferior poles of the kidneys get caught on the inferior mesenteric artery. So the kidneys cannot ascend past that IMA. So they remain in the lower abdomen. And these abnormally shaped kidneys can actually obstruct proper flow of urine, or even cause vesico-ureteral reflux. and whether from obstruction or vesico-ureteral reflux, hydronephrosis will result. And again, that will result in recurrent UTIs. Now here's a depiction of a horseshoe kidney, and you can see the inferior poles of the kidneys have fused together. And you can also see the inferior mesenteric artery right here. And so these kidneys, as they're ascending up, they get caught on this IMA. The last interesting detail about horseshoe kidneys is that they create an increased risk for renal stones. The exact mechanism isn't fully understood. One thought is that the abnormal shape of the kidneys, along with the stasis of urine, creates an environment suitable for kidney stones. Now that we've covered all this information in the table, let's do a quick question to apply what you've learned. The connection between the left ureter and the left renal pelvis did not recanalize as normal. How will this abnormality most likely be manifest clinically? Hopefully you notice that what is being described here is uretopelvic junction obstruction, which is caused by a failure to recanalize. And most often, this is a unilateral pathology, which is being described in this patient with a left-sided problem. Well, ultimately, the uretopelvic junction obstruction will lead to obstruction of urine, which will lead to hydronephrosis. And this will lead to recurrent UTIs. And it's these UTIs that are the most likely outcome clinically. For example, a worried mother will bring in the infant because of fussiness and a persistent fever. So that's the most likely clinical presentation. And that concludes this section.